Welcome to this chapter 17 podcast. The title of the chapter is Managed Healthcare. Uh, to start off, I should mention that Team 6 has been assigned to present the case at the beginning of this chapter and do a videotape case presentation. It involves a pharmacy benefit manager providing coverage for Sovaldi RX for hepatitis C, which is an expensive drug. So I'll leave that to Team 6 to provide you the case and the recommendations on that. Now, there are 18 pages of the textbook to read over. In this particular podcast, we have 23 slides. Now, in addition to these 23 slides, I'd like you to look over 4 tables. Table 17.1 is the characteristics of managed care plans. Table 17.2 is the summary of ethical issues in managed care. Table 17.3 is major categories of HEDIS measures. That's like report cards for healthcare. And Table 17.4 is incentives under various forms of hospital reimbursement, the different types of incentives under hospital reimbursement. Now, getting to it, there are 4 IRATs that we will cover as part of this podcast. So have your outline printed off, ready to make notes. There are 11 electives, quite a few here, but we'll address each one of those as we go through this. By way of the introduction to the chapter, you need to know that managed care organizations assume financial risk for expenditures and have incentives to control costs and utilization of health services. A good example of an MCO is Kaiser Permanente, which right now is basically out west. There are some Kaiser Permanente hospitals and facilities and clinics here on the East Coast, but they're still in the minority compared to out west. It was started by Henry J. Kaiser, an industrial contractor, to provide an entire medical delivery system for his 15,000 workers building the Grand Coulee Dam. Workers were covered for work injuries, but could cover other care for themselves and dependents for an additional 50 cents an adult and 25 cents per week. The Health Maintenance Organization Act of 1973 required employers with greater than or equal to 25 employees that offered a health plan to also offer HMO-type alternative to the indemnity plan that we talked about in the last chapter. Now on this slide, there will be an IRAT that comes from this particular slide, so listen up. The differentiating feature between fee-for-service plans and managed care is the use of provider networks. A provider network is a group of providers, physicians, mainly contracted to supply a full range of primary and acute health care services. There are 4 characteristics that differentiate the different types of MCOs. The risk-bearing, the physician type, the relationship exclusivity, and the out-of-network coverage. Now, for the IRAT, you'll need to know that the use of provider networks is a defining feature of managed care organizations as compared to fee-for-service health plans. So again, the use of provider networks is a defining feature of managed care organizations as compared to fee-for-service health plans. Moving on to the next slide, there's different characteristics that differentiate types of MCOs. We discussed that in an earlier slide, the one just before here, but we're going into it a little more. Risk bearing, the amount of risk borne by the provider, like the physician, which can range from full risk to no risk. The physician type, which is the relationship between the managed care organization and the physician or physicians. The relationship exclusivity, whether the physician provides care from one MCO only or to patients from multiple MCOs. So maybe you're visiting your primary care physician and you'll find out that he takes not only Blue Cross Blue Shield, but also Kaleida and Independent. That would be where they aren't that exclusive, whereas one that all they take is Blue Cross Blue Shield. Out-of-network coverage, whether care is received from a provider who is not in the MCO's network, is a covered benefit. So typically, if you're traveling and you can't find a physician in that network, you usually have to pay more for out-of-network coverage. So if you do get health insurance, a good thing to check on that. Sometimes they'll pay for out-of-network coverage and sometimes they won't, but maybe at a higher cost. Distinguishing characteristics of health maintenance organizations, they generally do not provide coverage for medical care that is received out of network. They place providers at risk, either directly or indirectly, through capitation, risk pools, and being a gatekeeper. Now, if you don't understand what that means, we'll get into it on the next slide. Capitation, providers are paid a predicted cost of care for a given population for a specified period of time, usually 1 year. They're obligated to provide all needed care for that population. So again, if it takes more money to take care of that population, then the provider contracts for the doctor or the physician would eat it, so to speak. Risk pools are a portion of payment, a withhold that is placed in a pool to cover claims that exceed projections. Physician and HMO share any surplus or loss at the end of the year. So again, if it's a loss, the doctor or the network, they have to eat it, so to speak. The gatekeeper, a primary care physician that must coordinate and authorize all medical services in order to be covered. Financially at risk, so as to minimize unnecessary services. So if you're in a particular network where the primary care physician has to okay to see some specialist, you better do that before you go see that specialist. Get that okay from the primary care physician who's your gatekeeper. Now there is an IRAT that comes from this slide, and you need to know that capitation is a type of risk sharing typically accepted by physicians participating in a health maintenance organization. Moving on to the next slide, there's also a higher IRAT that comes from this. So again, listen up. There's 4 types of HMOs, and we'll discuss this on this slide and the next slide. So these 2 slides actually come together. Staff model is the first type of HMO. The HMO directly owns facilities and providers are employees. Physicians bear no risk but are subject to utilization review therefore may influence care. So a good example of that would probably be Kaiser Permanente. There's the group model. The HMO contracts with large multi-specialty medical groups offering services exclusively to the HMO, and they are capitated. Now, I want you to know from this slide, a group model HMO is a type of MCO that requires physicians to contract exclusively with a single managed care organization rather than allowing them to contract with several. So that's exclusivity with that group model. Moving on with the four types of HMOs, discussing the last two, there's the network model, non-exclusive contracts with large medical groups. The physicians bear risk but reduced influence by the HMO. An independent practice association, the IPA model. Physicians form a separate legal entity that then contracts with the MCO. The IPA shares risk with the MCO. IPA contracts with physicians on a discounted fee-for-service basis, may or may not share some risk with the IPA. Contracted physicians usually have their own practices and can provide services to other patients and MCOs as well. Moving on to the next slide, types of managed care organizations. Now we're moving on to PPOs, preferred provider organizations. PPOs are affiliations of providers that seek contracts with insurance plans. There are non-exclusive arrangements. Individuals are free to seek any provider, but have a financial incentive to see those within the preferred network. Providers accept a discounted fee for service rather than capitation. Providers bear no risk, but along with the discounts, they are subject to utilization management and review to control costs. Exclusive provider organizations, EPOs, are a form of a PPO that strictly limits participation among providers. Then there, among MCOs, there are hybrid plans. Hybrid plans combine two or more organizational models. There's the point of service plan. The patients select a provider at the time of service is needed rather than upon joining the plan. Patient accepts different coverage for in-network and out-of-network providers. Providers may accept financial risk. This hybrid is these hybrid plans are becoming much more prevalent. Managing the pharmacy benefit. In 2013, about 90% of retail prescription claims were paid for, at least in part, by a third-party plan. Although not considered a managed care organization, pharmacy benefit managers have many of the characteristics of managed care, including a provider network. PBMs contract with a network of pharmacies. PBM services, getting a little more into it. There are limited networks, deeper discounts in return for increased volume. Prepare report cards for network pharmacies based on pre-selected performance criteria, which can be used to compare pharmacies. And they also have mail service. They run their own or contracted out. They take advantage of economies of scale. There's incentives for patient to use mail order when possible, such as a 90-day supply. There's negotiated discounts, generic substitution, and rebates. Rebates are additional revenue from manufacturers to PBMs for placing their drug on a formulary or preferred status. There's some ethical issues that emanate from that. Amount of rebate may be based on level of prescribing or market share within a therapeutic class. Proprietary information of PBM may or may not be shared with plans sponsored by contract. There's also claims adjudication. So if you go to this PBMs, you'll see a lot of this going on by clerks. Standardized electronic data interchange maintained by the National Council of Prescription Drug Programs, used for electronic claim submission, eligibility verification, and claims adjudication. Some of this includes formulary status of the drug, quantity or refill limits, the copay requirement, generic substitution or therapeutic alternatives, and information for drug utilization review. Also, under the purview of the pharmacy benefit managers are formularies. Formularies are a list of approved drugs. If it's an open formulary, all the drugs are covered. If it is closed, drugs not on the formulary are not covered. Incented, you have financial incentives to use preferred drugs. There are tiered co-payments. You've probably seen this on the cards that your patients show up at the front window with. There's the lowest copay for preferred drugs. There are higher copays for different levels of non-preferred drugs. And there are tiers in order of copayment. So you might have something like 10, 25, 50, where the 50 is the non-preferred drugs and the other two are the preferred drugs or generics. Incented formularies, again, looking at these tiers. There's generics, preferred brands, non-preferred brands, lifestyle drugs, so something like Viagra. It's got a much higher copay. And then there's non-formulary that is just strictly not covered by the PBM, and you have to pay 100% out of pocket. Oftentimes, these non-formulary are things like experimental drugs. Maybe they've just been put on the market. There's not much evidence that they do any better than some of the other drugs. Also, under formularies incented, there's the prior authorization program. The physician must request prior approval from a PBM in order to be covered, usually non-preferred tier or below. Good example is there are a lot of newer medications, injections for patients with diabetes, type 2. These are usually much more expensive. The PBM is saying to the physician, you can use these, but you have to use other less expensive drugs first. If you've used the less expensive drugs for a while and the patient still isn't getting their A1C down, then you can fill out this form. We'll authorize the patient to get the more expensive injection for diabetes type 2. There's step therapy. Less expensive first lines must be used and shown ineffective before more expensive second line or third line are covered. That's part of the prior authorization program, involves step therapy and also therapeutic alternatives under prior authorization program. Pharmacists are authorized to dispense other therapeutically equivalent drugs based on established guidelines for the prescribed. There's also therapeutic interchange or conversion, substitution, or switch program. The physician is contracted for approval. Patient may be also able to do this. Now, you see this in the hospital all the time where a patient comes in, maybe they're taking one particular kind of ACE inhibitor for hypertension. I mean, there's a plethora of different ACE inhibitors, and there's this authorization for the pharmacist to switch from, for example, captopril to lisinopril when the patient is admitted. They don't even have to talk to the doctor. Also, among the services provided by pharmacy benefit managers are drug utilization review. There's the review of physician prescribing, pharmacist dispensing, and patient use of medication. Ensures drugs are used appropriately, safely, and effectively. There's retrospective DUR, is an educational tool to inform providers of how to improve their drug therapy. And there's prospective DUR is done at the time of dispensing to determine if the prescription is appropriate. Now, I should point out here that prospective DUR is something I would say is probably your most important job as a practicing pharmacist is prospective DUR. This is something you're doing all the time. Retrospective DUR is something else. It's like somebody is looking at your records and determining if you're doing things right. So, for example, the State Board of Pharmacy has a retrospective DUR committee, and they look at all the, for example, all the Medicaid patients that you see and that you dispense for. And if they look at these records and they see a trend that you're not doing something right, they'll send you a letter and say, please show up at a disciplinary hearing and explain why you're not doing something, or you're not doing something correctly when you're dispensing, like you're dispensing something when you shouldn't, or you should change the dose. This can come with consequences, and be very careful when you get these retrospective DUR letters in the mail. Cost sharing, co-payment, co-insurance, or deductible. I think you know about those already. Provider and patient education, that's self-explanatory. Under this particular slide, there's an IRAT that comes from this slide. Provider and patient education, physician profiling. It's a report card on cost and quality dimensions. It's also on the expenditures per patient per month. There are benchmarks that compare physicians with others. And there's academic detailing or counter detailing where the plan representative provides physician with advice on how to reduce costs. Patient education is used to change behaviors to improve health. Now, you need to know from this particular slide, an IRAT, I want you to know that process is an example of the percentage of patients counseled per day. And it is an example of measures typically used to assess quality. So again, if you go back into the textbook, it talks about Don Obedian measuring quality by structure, process, and outcome. The percentage of patients counseled per day is really an example of process, which is an indication of the quality of your services. There are a lot of ethical issues surrounding some of the points that we discussed in this podcast. And you can get a lot of this from the textbook towards the end of the chapter. There are pro and con managed care positions. Some of the anti or the con MCO positions include the financial incentives undermine the physician's role as an advocate and patient trust, things like rebates. Ethics of medicine is replaced by ethics of business. There's some loss of physician autonomy when you have the PBMs telling, or the MCOs or the HMOs telling the physicians how to operate. And there's limits on patient choice. For example, they can't go out of network, or they have to get a doctor's approval to see a specialist. There are pro-MCO positions here listed, 4 of them. Fee-for-service provides financial incentives for over-treatment. Ethics of medicine are not necessarily superior to those of business, plus medicine is also a business. Physicians rarely have complete autonomy, which subsumes patient rights, and patients have limits under fee-for-service as well. The managed care organization market has adapted to add choice. Now, oversight and accreditation. Primarily, state insurance departments have oversight of managed care organizations to ensure compliance with state laws and regulations regarding issues such as financial solvency, enrollment procedures, and patients' rights. Again, this goes to the Constitution of the United States of America and the Police Powers Clause. There are 3 major accrediting agencies that we call voluntary. We've talked about this before. The National Committee for Quality Assurance, the Utilization Review Accreditation Commission, and the Joint Commission for the Accreditation of Healthcare Organizations, abbreviated just the Joint Commission. And finally, this last slide for the podcast, the NCQA is the main agency for HMOs. They submit it to accreditation more than any other type of MCO. It accredits PPOs as well. There's the Health Plan Employer Data and Information Set. You'll get more of this in the pharmacy management course. HEDIS, H-E-D-I-S, stands for Health Plan Employer Data Information Set. It provides plan sponsors a set of objective measures with which to evaluate MCOs. So if you go to a HEDIS website, you can see how different MCOs are rated according to these HEDIS measures. Trying to think, the last time I looked at that website, there was a health plan in Pittsburgh. I'm trying to remember the name of it. But it was the top MCO in the country for using these objectives. Utilization Review Accreditation Commission, URAC, is the main agency for PPOs. It accredits HMOs as well, provides a detailed process with both on and off-site components. And with that, we finish this podcast. Thank you.